Hello everyone, this is a small presentation that I put together in about a day yesterday for a small club that I'm running at UCLA. So this is basically a presentation about my case, a small case that I made against the use of full coverage crowns. Without further ado, let's dive into this. So which is better? Having more tooth structure? This is my first question to you. Which is better, having more tooth structure remaining or replacing tooth structure with stronger restorative material, right? What do you think is better sort of inherently? So my opinion is that having more tooth structure is better most of the time. I believe that nature has the best restorative material and nature has the best biomechanics. For those of you who don't know, biomechanics means sort of like the physics of how a tooth handles stress and how the tooth moves, sort of like the physics of a tooth. But exceptions to this rule is when cusps are like those pointy parts of the top of the tooth, for those of you who don't know. So if the cusps are too thin after you remove decay, after you remove like a previous restoration on the tooth, after you're done drilling the tooth, if there's too thin cusps remaining, or enamel, that thin piece of enamel that is there and could easily fracture off. In those cases, it's better to replace them with a restorative material. So for dental students, these cusps are called tension cusps. So, not these cusps. I'm particularly concerned with tension cusps when I talk about this. So tension cusps are weak cusps because they're under tensile forces, and thus they're often the first ones to fracture off. So tension cusps are basically non-functional cusps. So if you've learned in dental school, functional cusps are the cusps, maxillary lingual cusps and mandibular buccal cusps, right? Those are the functional cusps. Those are the ones that are primarily used for chewing food and function, right? And the maxillary buccal cusp is a non-functional cusp, and the mandibular lingual cusp is also a non-functional cusp. So functional cusps, because this is the tooth, sort of like the middle of a tooth, and this is the opposing tooth. Functional cusp is sort of like held together, sort of hugged by the opposing tooth, right? But the non-functional cusp is like right here. It's only contacting on one side, so it's under tension, not compression. So non-functional cusps are under tension, and they're called tension cusps. And a good acronym to remember this is BULL, bull, buccal upper, lower lingual. And because tension cusps are often weaker because they're under tensile forces, the rule is to onlay these cusps if they are less than 3 millimeters thick. For functional cusps, onlay them if they're 2 millimeters thick, because functional cusps, you can actually get away with a thinner cusp because they're under compression, not in tension. I wish I could find the literature for this. I've learned this somewhere from Biomimetic dentists, but I could not find the literature for this, this rule right here. And onlay, for those of you who don't know, is cusp coverage restorations. So there's fillings or inlays. They are within a tooth, top surface of a tooth. And onlay is covering at least one cusp, whereas inlay or filling doesn't cover a cusp. It's usually along the grooves. So here, a demonstration of a mandibular posterior tooth. The buccal cusp on the left side here is under compression forces, whereas the lingual side, it's going this way and it's under tension forces. So that's why the lingual cusp of the mandibular posterior is often fractured more frequently, especially the mandibular first molars. Okay, so let's talk about crowns. The first ever crown was introduced in 1889. It's called the porcelain jacket crown. It was a all porcelain crown. And porcelain fused metal crown, PFM crowns, were developed in 1950s. Why was it developed? Because porcelain jacket crowns keep fracturing. Now ask yourself, why does it keep fracturing? Why? Because porcelain is not a very strong material. That's number one reason. Number two, they didn't know how to bond back then. They didn't know how to do adhesive dentistry back then. All they were relying on were big, broad, mechanical, physical retentions. to keep these restorations in place. They didn't know how to bond. So what is the indication of a crown? Let's think about this. This is more for dental students. It's probably hard to understand if you're not a pre-dental, but try your best to follow through if you can. But what is the indication of a crown? We're told that we usually crown a tooth when there's a little tooth structure left, right? But then you have to ask yourself, why do we cut away even more tooth structure? Because you know what, there's a little tooth structure remaining, but why do we cut the tooth even more into a crown preparation to crown it? The reason is it's retention form. So retention form, you need like a convergent nub of tooth, and it has to be tall enough so that a crown can go in and not easily fall out. A tall enough nub provides good retention form because it helps the crown stay in place, retention, right? However, with today's dentistry, adhesive dentistry, bonding is basically like a glue, right? It glues either composite or ceramic to the tooth, right? It's different from just capping a tooth as a crown. Like a cemented crown is just putting a crown on a nub and filling all the spaces with the cement so that through friction, it holds it in place, right? Whereas bonding, you use a very flowy resin that would actually infiltrate into tooth structure and then also into the ceramic or the composite. And then they actually bond like a glue, right? I don't know if that makes sense, but for pre-dentals out there who doesn't know what bonding is basically using resin to glue restorative material onto the tooth. So it's glued on, so you don't really need like a tall tooth to keep it in place. You don't really need retention form. So bonding eliminates the need for retention form. And also another indication of a crown that we're commonly taught in dental school is that a crown holds a cracked tooth together. But does it or does it not? But it depends. It's not always like that. It depends. So if a crown is not bonded, then it doesn't necessarily hold the tooth together. If a crown is only cemented on, if it's not glued on, but just capped onto the tooth, if there was a crack underneath the crown on the tooth, as you bite on the crown to eat and function, the crack will continue to propagate down the tooth. And don't be surprised if a tooth with a crown that was doing just fine, for 5+ years, suddenly gets sensitive and suddenly needs root canal. Here's a good example. I found this from Dr. Schiffenhaus's Instagram account. So he removed this. So this patient came in and the patient had a non-bonded crown on this tooth. And this tooth was doing fine for like 10+ years, but suddenly its nerves got infected and the patient is in pain and the patient needs root canal treatment. So we're like, what happened? And he removed the crown and he found a huge crack on the mesial side of this tooth. You can see there. And he chased the crack down. He tried to drill it out, remove it, but he had to keep going because the crack was moving all the way down and it reached the pulp, it reached the nerve. So what happened was, because of this crack was propagating, bacteria can get inside this crack. This crack, it looks small to our eyes, but to bacteria, it's a large space. So bacteria can get inside this crack. You can see the crack right here. Bacteria can get inside this crack, and as crack propagates, as the crack deepens, bacteria can also follow through, and then eventually infect the nerve, reach the nerve. And once that happens, then you will have all sorts of pain and you're gonna need root canal treatment. So this is one anecdotal proof that non-bonded crowns don't hold the tooth together, especially when it's cracked. It doesn't hold the cracked tooth together. And it makes sense, right? A bonded crown which is stuck to the tooth, when you chew on it, right? Because it's glued onto the tooth, when you glue it onto the tooth, the whole tooth and the crown becomes one physical entity, right? They're no longer separate. They're one physical entity. So when you chew on that bonded crown, the stress distribution from the chewing forces is evenly distributed throughout the tooth as opposed to just the crown and then separately to the tooth, right? If a crown is not glued onto the tooth, it's just kept on top of a tooth without bonding, then there's going to be micro movements, like the crown will have micro movements that are independent from the tooth. So the stress distribution patterns are also separate and often detrimental. So it makes common sense, right? It makes sense if you think about this thing. It's like analogy, like capping a tooth versus gluing onto tooth, right? Which is going to have a more favorable stress distribution when you bite on it. What is an indication of a crown? Oh, sorry. This is the same slide. So we're continuing. So we talked about little tooth structure left. That's when we crown. We're taught to crown in school. Also, when there's a crack in the tooth, we hold it together with the crown. That's how we're taught. But as I've gone over both of them don't necessarily need to be crowned. And also another indication of a crown we've been taught in school is that endo-treated teeth. Endo-treated teeth are teeth that have received root canal treatment. And in school, we're taught that root canal treated teeth, because there's no nerves anymore, there's no food supply to the tooth anymore, no nerves, no blood supply, the tooth becomes brittle, right? But this is a myth. Some schools will teach you this, but this is a myth. The tooth itself doesn't become brittle. The quality of the tooth structure dentin is actually the same whether the tooth is alive or whether the tooth is dead. But the reason why root canal treated teeth fracture more frequently than a natural tooth, a virgin tooth, no root canal treatment, is because of the root canal was started because the nerve got infected, and probably it was infected because of some kind of decay or some kind of fracture, some kind of trauma, right? So because of decay, trauma, and you have to remove it, you have to drill it out, and you drill all the way down to where the nerve is to do a root canal. And then when you do root canal, you drill some of the inside walls of the roots away. So there's a lot of drilling. A lot of tooth structure has been removed usually for a root canal treated teeth. That's why root canal treated teeth fracture more than a regular virgin tooth. Not because the tooth structure itself was brittle, but because there's less tooth structure remaining. The tooth has been structurally compromised, okay? Think of tooth as like a perfectly designed architecture building, right? Designed by nature, right? You start drilling on it, and then you expose the dentin and you take away certain important parts of the tooth structure becomes compromised, the tooth's gonna start flexing in all different directions. And it's a matter of time before the tooth fractures. And this is more for dental students, but for front teeth, anteriors, we don't have to crown it. Some schools teach you to crown it, but the anteriors, you can get away with composite restoration. Oftentimes, shaving down root canal treated anterior teeth for a crown actually sometimes worsens the prognosis, because you're removing so much tooth structure and the anterior teeth are already small, and also anterior teeth, the occlusion, the bite force is not very heavy over there, so you can get away with composite. And composite, if it fractures, you can always repair it. Whereas if you crown it and then the tooth fractures, it often fractures like irreversibly. Like you get a big fracture, like the whole crown just fractures off. That often happens more with crowns versus if you just use a composite restoration. Posterior teeth, the back teeth, the heavier occlusal forces, we're taught to crown it in school. But I'm here to tell you that you don't have to. I'm not going to get into the details, but there's enough published literature to show that you can do this. You don't have to do like a conventional cap-like crown, but you can do an endo crown or an endo onlay. So these are basically, instead of doing a cap-like crown, endo-treated teeth usually have in the middle, there's like a hole going in, because you have to drill into the pulp to access the nerve, to remove the nerve, right? So there's usually a hole in the middle. So instead of doing a cap, just engage that hole with restorative material, right? So here, let me demonstrate here. So the middle here and the right side, these are endo crowns, okay, endo crowns. And on the left side, these are endo lays, essentially onlay, but on an endodontic tooth. So traditionally, what we would do is we would, either there's like a middle big cavity here, this was created because we had to do a root canal. And then traditionally, we would use maybe like a post or something and use amalgam or composite and build it back up like a nub for a crown, right? Like a crown prep, right? and then we'll put a crown on it, a traditional crown. This is like a reversed crown, right? Because we're not doing that. Instead, we're actually trying to engage the inside here for attention, right? So this is like a reversed crown, also called the endo crown. And this has just as much success. Actually, I think this had better success than traditional crowns, according to literature. And especially endo lays here, these also had really good success. And these also don't require you to remove so much tooth structure, anymore. You see here, you remove some tooth structure to get some of that ferrule effect here. This is a ferrule. It's good for retention, and it's good for it's sort of, the theory is that the ferrule sort of helps, it prevents it from moving so much, and also prevents, if the restoration fails, it prevents it from failing, like cracking the tooth. It's like physics, you have to think about it. Like, anyways, the details are not very important. I'm here to just tell you that traditional crowns are no longer the best solution for endo-treated teeth. You can do an endo onlay or an endo crown. And these are more conservative. You don't have to remove so much tooth structure. Finally, the last indication of a crown that is commonly taught is to change the shade of the tooth, change the color. Maybe the tooth is dark, maybe it's tetracycline staining or something, right? But even then, you can just use veneers. Veneers are partial coverages. It covers the outside surface and the occlusal and the biting surface, right? Actually, you don't even have to cover the biting surface if you don't need to. If you're just changing the look of the tooth on the outside, just cover the outside. It's a veneer, it's a partial coverage. You don't need a crown. So when do you use a crown? Like all these indications that we're taught, little structure left, you don't have to use a crown. Does crown hold teeth together? No, not necessarily. Endo-treated teeth, you don't need a crown. Changing shade, you don't need a crown. So when do you use crown then? Maybe if all 5 surfaces of a tooth has decay, then maybe it makes sense to use a crown. But this almost never happens. This is really rare. You almost never see a case where all 5 surfaces have decay or some kind of trauma. And usually if that happens, usually you're at a point where you're thinking about extraction because tooth has been destroyed so much. So I think the only true unique indication of a crown in today's day and age of adhesive dentistry and partial coverage restorations, I think the only indication is replacing failing crowns placed by whatever previous dentist somewhere else, or placed by you back then you used to crowns. So only replacing failing crowns is the only time I think that is an appropriate time to use crowns. Because when you're replacing failing crowns, the tooth already has been prepped irreversibly into a crown prep anyway. So, but then why is crown is still around and still placed by so many dentists? The reason is we are taught how to do crowns well in dental school, most dental schools. We don't get much experience with partial coverage. Crowns are, therefore, we find it easier, right? Therefore, it's faster in our hands, and it's actually more lucrative. It uses more restorative material because it's a full coverage versus a partial coverage. Partial coverages are usually cheaper, even though it's more decay sensitive. So it makes you more money and it's faster. That's why it's being used, but it's very aggressive. It's not conservative, and it's no longer, in my opinion, the best restorative treatment option for a lot of cases. Okay, now let's think about this. You might say, okay, is there harm in doing crowns? And as I just said, it's not conservative. The incidence of post-operative sensitivity is a lot more common with full coverage crowns than partial coverage because you're oftentimes prepping the side walls, the axial walls, like past the pulp, where the pulp is, right? So you're getting very, very close to pulp. And it's not uncommon to see people complain of pain after a crown preparation appointment. And because you've removed a lot of tooth structure, I've read a study that says that an average crown, the coronal tooth structure, the crown portion of the tooth structure, 70% of coronal tooth structure is removed. You're left with 30%. You remove so much tooth structure, that is irreversible damage. And whenever you drill on a tooth, you start the tooth on a restorative cycle. That tooth is very likely to get some kind of recurrent decay, some kind of leakage, and then we'll need another treatment after, and then we'll need another treatment down the road. And this is a cycle called the restorative cycle. Once you drill on a tooth, it starts the restorative cycle. And when you're looking at down the road extraction and implant, you know. So you're making this restorative cycle faster by removing more tooth structure that is necessary. So it's not conservative, also unethical in my opinion. Complete removal of the DEJ. So DEJ is a dentinal enamel complex, dentinal enamel junction. So for pre-dentals, it might be confusing because I haven't gone over the anatomy of a tooth, but basically the outside of the tooth is let me see if I have a picture or not. I don't, huh? Oh, here it is. So on the outside, this white area is enamel. This yellow area is dentin, right? And then the border between those two is called the DEJ, dentinal enamel junction. It's the junction, right? So let me go back. So the DEJ, it serves a purpose. The purpose of the DEJ, like I said, nature has the best design, right? So the DEJ is nature's crack stopper, nature's way to stop tooth cracks. So enamel is very strong, but also brittle, kind of like a ceramic, strong but brittle. And oftentimes as you age, you will start developing a few cracks here and there on the enamel. You can kind of see it. And older patients, I see it on their teeth routinely. But the tooth doesn't break in half. So you have to ask the question, then where do these cracks go, right? You see it on the outside of the tooth, but the tooth is still intact. And the reason is that the crack is deflected as soon as it reaches the DEJ. So it doesn't actually reach the dentin. So DEJ functions, it's a fiber. It's a complex series of fibers holding the enamel and dentin together. And when the crack reaches the DEJ, it goes vertical and then becomes horizontal. So it actually protects the dentin. Because if you have a fracture in the dentin, then you're looking at down the road, root canal, and if the fracture goes all the way down to the root, then extraction. So DEJ is very important. It's a crack stopper. But in a crown, you're removing all of that. Because when you do a crown preparation, you're usually removing all the enamel away and exposing all that you have left is dentin. If all that you have left is dentin, then you know you've already removed the DEJ, right? So you're removing the tooth's ability to stop cracks, and you're removing all that away. And also, when you do a crown preparation and put a crown on, the margin of the crown is actually placed on the weakest area of the tooth, the cervical 1/3. Cervical 1/3 is the bottom 1/3 of the teeth. So here, where I'm pointing right here, this is the cervical 1/3 of the area of the crown. And usually this is where the crown margin ends. And the reason why this is bad is that so these lines are stress lines. Whenever you bite on a tooth, stress distribution looks kind of like this. And there's a lot of stress lines near the bottom here, right? A lot of stress fringes are concentrated on the bottom 1/3 of the tooth. And oftentimes, because of this, you see people fracturing their tooth right here, right there, right? So people fracture teeth here, like, it's not uncommon to see that. It's called an abfraction. But a crown places the margin right here, where there's a lot of fractures that occur. So when you compromise this area, the 1/3, bottom 1/3 of the tooth, there's a term for it. It's called a biorim. When you compromise this area, you weaken the tooth a lot, right? Think of this area as sort of like the wall to a cathedral, right? And the enamel as like the dome, right? and this area, the biorim, as the wall of the cathedral, right? You smash the wall and the integrity of the cathedral is really compromised, right? So it's very, very bad for longevity. If you want good longevity on your restoration, you don't want to destroy the biorim. You want to keep it preserved. You don't want to prep it away when you're doing a crown prep. So that's another reason why crowns are harmful, because you're removing the cervical 1/3 of the tooth, the weakest area of the tooth. And preservation of the biorim, this area, is very important for long-term success. And let me prove it to you. So here's a really useful study here. It's a lot of numbers. Let me digest this for you, okay? So you don't have to look at the first, so there's 6 groups here. You don't have to look at the first 2, just look at the last 4. So the middle 2 here, TCA and TCU, they refer to endo-treated crowns, right? The reason why there's 2 variations is because they use 2 different kinds of cements, but it turns out the cement didn't make any difference anyway. So treat these 2 middle as one group and treat these bottom 2 as one group. So the middle 2 are endo, got root canal, and got a conventional crown, the full coverage crown. And then the bottom is got an also root canal, but an onlay, which is a partial coverage, right? Actually, I should probably go over what an onlay is real quick here. For those of you who don't know what an onlay is. So onlay is, instead of prepping a tooth all the way down, all around, you're only prepping the top part, right? I'm trying to simplify this as much as I can, especially for pre-dents. So you can see here on this image, only like the top portion of the teeth are prepped. The margins here all around are not placed all the way at the bottom of the tooth, right? So a crown will normally go all the way down, right? An onlay and overlay stops wherever it needs to stop, right? It doesn't go past the biorim, right? I hope that makes sense. I realize I didn't make this presentation geared towards pre-dents, but I understand that when I put this video up on my channel, a lot of pre-dents are going to probably watch it. Hopefully some dental students get to see this as well, and we can have some discussion. If you disagree with me, I am always open to discussion. Okay, where was I? So yeah, so a root canal treated tooth with a crown, these 2, and root canal treated tooth with an onlay, which is like a shorter version of a crown, not going down all the way to where the biorim is. Here, there's different kinds of failure modes. They got these tooth, you know, endo-treated crown or onlay, and then they hit it, right, until they broke. And then they looked at the way in which they broke, right? And it turns out root canal treated tooth with a conventional crown, all of them, 10 out of 10 of them, actually 20 out of 20 of them, all of them, broke catastrophically. You see here, 10, 10, both endo-treated crowns, catastrophic, right? Catastrophic meaning the restoration broke, the crown broke, as well as the tooth. The tooth also broke. And catastrophic means you can't save the tooth. It's a catastrophic failure, right? Whereas an endo-treated tooth with an onlay, where they didn't prep all the way down, they preserved the biorim, only restored the top. You can see that less than half, so you can see that the most common way in which it fractured here, number 2 here, right? This fracture mode number 2 here is the most common way in the fracture, and the fracture mode number 2 here refers to less than half of the restoration has fractured off. So there's the full restoration, and only less than half of it fractured off, and the tooth was fine, right? So this is the most common way in which it fractured. Let me demonstrate this with the visual. So this is the most common way in which these teeth fractured, or these restorations fractured. So A is vital tooth, no root canal treatment, just the conventional crown. And then they loaded it until they fractured, and the most common way it fractured, it was straight down the crown, but the tooth underneath was fine, right? But B, root canal treated, right? And then they, rolled it until it fractured. And then the most common way it fractured was, down the midline as well. But also you can see the tooth has also fractured, right? This cannot be saved. The one on the left side, you can at least replace the crown. This one on the middle, you can't save this tooth. You got to extract an implant because the tooth has fractured off, right? And on the most right side, this is an onlay, root canal treated tooth and an onlay. And you can see here where I'm pointing at, they didn't remove all of these bottom 1/3 of the tooth structure. The biorim is preserved. The weakest part of the tooth structure, this part is preserved. And the most common failure route was less than half of the whole restoration fractures off. The most conservative way to fail, right, has been seen with the onlay. There were 0 instances in which the tooth fractured, 0, right? Whereas a tooth that had no root canal treatment but a regular crown had, you know, a good amount, about 6, right? Whereas root canal treated and a regular crown, 100% of them, the tooth fracture, right? So clearly, onlay is the best option here, right? At least according to the study. So this teaches us a really important lesson that the biorim should be preserved, right? Biorim should be preserved. Is there a harm in using crowns? Last point about this. If you don't bond a crown, if you just cement a crown, you know, it can work fine. If it's gold and you do it right, good margins, it can work really well, as long as there's enough tooth structure remaining underneath. However, if when it's not done well, right, which is probably a lot of cases, you're very prone to have marginal leakage, slight opening at the margins of the crown, in between tooth structure and the crown. If there's slight opening, then bacteria gets inside and you're looking at decay. Or if there's a crack underneath the crown, a non-bonded crown, like I showed you before here, the crack can develop right here and go all the way down, right? A non-bonded crown does not stop a crack. So a bonded crown, you know, if you chase the crack and then bond on top of that, and also bond the restoration really well, then you can potentially stop a crack. And also margin leakage. If you get a nice, I'm assuming you're bonding really correctly, right? So if you do a good job of bonding and you get a nice seal at the margins, you polish that margin really nicely. A bonded margin is so much better than a non-bonded metal margin. Metal margins are pretty good, right? But if you compare a really well-done metal margin versus a really well-done bonded ceramic margin does better. There is less space, less microns of space in the margin for bacteria to get in compared to a metal margin. And this is especially true if you use a heated composite cement, because heated composite cement, you know, polishes well and just completely seals that margin up. Sorry if I'm not making sense for pre-dents. Now we're already so far into dentistry that I don't know if I can, you know, dumb it down any further than this. Okay, now what's the alternative to crowns? Because all this time we've been talking about how, you know, crowns are not very useful in this day and age. So my suggestion is E.max onlay or an overlay. So onlay and overlay, like I said, only covers the top of the tooth. It's a partial coverage. It covers the cusp. It doesn't prep away the rest of the sides of the tooth, axial. It doesn't prep away all the axial walls of the tooth. It preserves the biorim. So here, the benefit is it preserves more tooth structure because it's bonded. You don't need to prep away more tooth structure. The only reason you prep away more tooth structure is you got to have a tall enough nub for the crown to stay on, right? If it's not tall enough, then it's gonna fall out. So you don't need retention form anymore. No retention form needed because you're bonding. So you're not prepping away as much tooth structure anymore. So it delays the restorative cycle, and there's less post-operative sensitivity as a result of that. And especially if you employ immediate dentin sealing to seal all the dentin tubules, then you're definitely not gonna have post-operative sensitivity. The DEJ is preserved because you're not removing all the DEJ by prepping the axial walls. So the ability of the remaining tooth to deflect crack that was started in enamel is preserved. So crack deflection ability is preserved. And also the DEJ is the area where you get the highest bond strength, even more than enamel. Enamel, you can get bond strengths up to 30 megapascals, but on the DEJ, dentin enamel junction, you can get up to 50, 60 megapascals, right? What does that mean? You get a really incredible seal of the restoration. And also, when you bond the restoration really well, the restoration also becomes tougher to fracture. And I haven't mentioned it here, but the DEJ also helps dissipate stresses that are coming from the enamel, especially tensile stresses. It dissipates the stresses really well. As soon as like a tensile stress comes from the enamel onto the DEJ, it sort of dissipates instead of going directly into the dentin. So that's another advantage, stress dissipation. And obviously, you're not prepping away all the axial wall. So by the biorim, the cervical 1/3 is preserved. The weakest part of the tooth is preserved. So there's no marginal damage, no worries of like an abstraction destroying the margin of the restoration. Tooth is stronger because you haven't prepped this important part away. I would call the biorim like the Achilles of the tooth, Achilles heel, right? You want to keep it there. You don't want to, you don't want to damage it, right? As soon as you damage the Achilles heel, the whole tooth is weaker, much weaker. So as a result of that, as we saw before in the experiment, that's if you keep the biorim, there's less catastrophic failures. Even if you have a failure, it's not catastrophic, it's repairable and minimal. And a bonus is because you're not prepping way all the way down, you're staying relatively high up in the tooth. The margins are very supragingival. Supragingival meaning the margins are usually way above the gum line. If the margin is way below the gum line, it's just difficult for the dentist to work with, especially if you're trying to bond, because bond, you don't want any saliva there. So if the margins are high up on the tooth, it's easy to isolate, just makes our lives easier as dentists. So I'm not going to go into details, but a ceramic, like an E.max overlay prep design looks very smooth. It almost looks like a flat table. If you look here on the bottom, it almost looks like a really flat table. It's basically very rounded and smooth everywhere, so you don't have any stress concentration points. And for the details of the prep design, just read this paper that I cited or take Dr. Shifanas's course in BARD, B-A-R-D. Okay, let's talk about natural tooth biomechanics. Very important. Nature's biomechanics. Nature's designed for physics of the teeth, right? So the enamel acts like a compression dome. A compression dome is a concept in architecture where like there's a cathedral, like a building, and then the roof is like a dome, semicircle dome, right? And the benefit of this is any stress placed on it becomes compression, and it's distributed evenly throughout the tooth as compression. It only becomes tension forces near the bottom part of the dome. And the tooth case, the cervical 1/3, the biorim, the weakest area of the tooth, that's where the stresses become tensile, tension forces. Tension forces are not favorable. Tension forces are like pulling things together, right? Compression forces are pushing things together. The tooth can take compression forces really well, but not tension forces. Tension forces are very traumatic. So enamel functions to evenly distribute compressive forces. And some important structures that you should try to avoid drilling away because it will really compromise the structure of the enamel. Structural integrity of the enamel is oblique transverse ridge, peripheral rim of enamel, and maxillary rainy web, which is apparently the mesial fossa of the first maxillary first molars. This is more for dental students. So as I mentioned before, the DEJ/the DEC, dentinal enamel junction, or the dentinal enamel complex, whichever term you want to use, is actually a series of fibers, the fiber complex. And as I mentioned before, it has a function, it acts to deflect cracks that come from enamel, so the dentin is protected. It also transfers force coming from enamel and maintains the force as compressive forces on dentin, not tensile forces. And the dentin, compared to enamel, the enamel is it's like similar to ceramic. It's very strong but brittle. Very strong but brittle. Dentin is not as hard like enamel. It's a little more flexible, So it has a little more give. It can absorb stresses a little better. So it's more elastic. It absorbs the rest of the forces that were not absorbed by the enamel and the DJ, okay? And the cervical 1/3 is the tooth. The bottom 1/3 of the tooth is called the biorim, the Achilles heel of the tooth. Stress is concentrated here, as you can see on the stress fringes here. There's a lot of stress lines. This is the weakest part of the tooth. This is where often there's fractures. And you want to avoid placing margins here. You want to avoid removing this tooth structure. You want to keep this intact. You can only do that with onlays or overlays, not with crowns. And again, this is this is the enamel compression dome here. When force is applied from the top, you can see it's mostly compression, compression, compression until the bottom 1/3, right? Then you get tension, right? So that's just to illustrate that force distribution becomes tensile forces near the biorim, and biorim therefore must be preserved. And so this is a little more complicated, but an overlay, this is more for dental students. So in order to build a tooth from bottom to top, similar to nature, right? Not just like slapping on like a metal or slapping on like ceramic and be done with it, but building the tooth layer by layer from the bottom to top, trying to mimic the layers of an actual tooth. That way, we can have the best physics, best biomechanics for the tooth, for the stress distribution. So here for enamel, the top part, the outer surface of the tooth, enamel is strong and brittle. So what mimics that? E.max. E.max is ceramic. It's lithium disilicate. It has a similar modulus of elasticity as enamel, which is flexibility / brittleness, right? Similar to enamel. If E.max is not an option, you can also use an indirect composite overlay. If when done right, when bonded correctly, it performs at a similar level as E.max. You can check out Dr. Davey Alleman's Instagram page for more information on that. And dentin, you use fiber reinforced composite. There's a whole slew of literature about fiber reinforced composites, and it will take another whole lecture to cover that. But the bottom line is it mimics dentin really well. So it's a good dentin replacement. The DEJ can be mimicked by the biobase, especially the resin coat layer. So the biobase is a combination of immediate dentin sealing, maybe a fiber insert optional, depending on how big the cavity is. If it's big, might be useful to put a fiber insert. And DEJ is essentially a fiber, right? So fiber insert is theoretically supposed to sort of mimic the function of the DEJ, and also flowable resin coated layer. So each part of this, part of the biobase, is also another long lecture to cover each one. Basically, the function of the biobase here is to protect the bond and also to act as a fail-safe layer. As in, if the E.max ceramic fractures, fails, then the fracture will stop at the flowable layer, right? So the flowable layer is the fail-safe. So the flowable layer, restoration failures will happen almost always at the flowable layer and not deeper than that. So the bond to dentin and the bond to tooth will be saved, will be preserved. What does that mean? It acts just like a DEJ. It stops the crack, right? It deflects it, right? So that it doesn't propagate all the way down to the tooth and dentin. And the benefit of that is you can repair it, right? If the bond is okay and the tooth is okay, it only failed at the flowable layer, then you can totally just bond another ceramic on top of that, and it's a very repairable failure. And the cervical 1/3, we can mimic that by not removing anything, right? Not removing any tooth structure. We can just leave the nature's Achilles heel intact, right? Preserve the biorim, don't drill it away, right? And also the most important part is you have to bond. You can't just cement, you have to bond because there is no retention form on these preps, because we're not prepping away all the way down. We're preserving the biorim, we're staying on top and removing, and we're not having any retention like boxes, grooves, or notches, right? Because those are stress concentration points. So we're not having any of that. So you have to bond. And the best leading agent for these are heated composite or panadia, 50 to 100 microns of cement thickness. You don't want the cement to be too thick. Then it starts backfiring. There's a whole nother paper on this as well, but I'm not going to go into details, but this is the protocol. And here's some evidence to show that E.max onlays and overlays have good longevity. So we've often heard that E.max doesn't last long because it fractures, right? Metal's stronger. But you have to ask them first, okay, when you say that E.max doesn't last long, did the doctor do it correctly, right? Because bonding E.max is it's not straightforward. You need to be trained to bond properly. Bonding is, when you're bonding, as soon as you have any kind of contamination, so like a little drop of saliva, then your bond will fail. As soon as if you don't control for like shrinkage stress of like composite, for example, the bond will fail again. If you have a high C factor preparation, the bond will fail. If you don't let the bond mature for a longer time, the bond may likely fail. If you don't remove caries all the way down, if you bond to caries, it's gonna be a weak bond. If you don't clean the DEJ, if you don't have a clean DEJ to bond to, you're not gonna get a good peripheral seal, you're gonna get a weak bond. There's so many ways that bond can fail, right? So I personally believe that's why they say that E.max doesn't last as long as like metal ceramic, for example. And here's a study to examine that, right? So the first one on the top left, it's a 4-year clinical study between 2 dentists. One of them was unexperienced, the other one was very experienced with bonding. The unexperienced operator had a failure rate of his E.max inlays, onlays of 25%. 1/4 of his cases failed over 4 years. If you don't know how to bond, you might as well not do it. But an experienced operator over 4 years had 2.6% failure. Much, 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 much less. Very clinically acceptable, very good performance, right? So you have to ask yourself, when you say that E.max fails, make sure that they did it correctly, you know? Otherwise, it's not because of the bonding and E.max, but it's because of the operator, right? So there's also, okay, now in terms of actual longevity of this restoration, when they're done right, so when they're done correctly, here on the right side, 3 clinical trials examined, and they came to a conclusion that the survival rates of E.max onlays partial crowns were between 96 and 100% over 7 to 10 years, very good. And this is a little more anecdotal, but this is one of the people, this is the doctor who actually wrote the enamel compression dome paper, very, very famous paper in the biomedical community. So Dr. Milicic on the bottom, he's bonded more than 3,000 lithium disilicate partial crowns, which are E.max, over a period of 9 years without any retention form, right? Just like those flat prep designs that I showed you before. Only 2 fractured, 2 out of 3,000. And even within those 2, there was no debonding. The bond was preserved. So it's repairable. So if you know how to bond correctly, you can achieve incredible success, and you can do a patient a service by not prepping so much teeth to structure away, right? And also build a tooth from bottom to top, like how nature built tooth, layer by layer, right? But critics will still say, isn't PFM stronger than E.max? Yeah, on its own, yeah. On the PFM itself and E.max itself, yeah. If you try to do fracture tests, PFM will win. But you have to realize that the material strength isn't the only factor determining longevity of a restoration. There's also the bond, and E.max gains significant strength once it's bonded, right? It becomes so much stronger, right? Not only that, but once bonded, it distributes the stress on the tooth evenly all the way throughout the tooth, whereas a PFM, it's a separate entity from the crown. So the stress distribution patterns are different, like I said before. It does not stop a crack because of that. And here's actual data. Longevity of bonded E.max crowns versus PFM crowns. There's no difference. And here's data. So on the top, metal ceramic, where I'm pointing to, examined a lot of papers, the systematic review study. On the bottom, here's lithium disilicate reinforced glass ceramics, E.max. An estimated 5-year survival, right, in percent, 95.7% for metal ceramics. Pretty good. 96.6% for E.max. That's pretty much no difference. It's pretty much the same. So there's no difference in the 5-year survival rate. Maybe it's different or longer than that, but in terms of 5-year survival, it's the same. But the added benefit of properly bonded E.max crown over a properly done PFM crown, properly cemented PFM crown, because PFMs can't be bonded. A bonded E.max crown can have a better marginal seal. The marginal gap is less than a PFM's metal margin. Therefore, less chance of bacteria getting inside the margin to create recurrent decay. And a bonded E.max crown can stop cracks if you chase the crack, if you do it right. All of these, I'm assuming you've done it right, right? So if you chase the crack as much as you can, and then bond composite on top of that, seal everything with IDS bond, and nice flowable layer, controls stress, shrinkage stress, and everything. You employ all these biomimetic protocols, right, to get good bond. You can stop a crack. You can hold the tooth together. Bonded but a PFM crown cannot because it's not bonded. A bonded E.max crown distributes stress evenly throughout the tooth. It functions as one unit, whereas PFM crown restored teeth function as 2 units, crown and tooth, separate, different kinds, totally different stress distribution patterns, versus a bonded E.max crown, 1 unit, right? But why do E.max crowns fail? It's because of improper bonding technique, not because of material strength, okay? I emphasize it again. Okay, this is a disclaimer. I know I've talked a lot about ceramics here and the advantages, but this doesn't mean that metal is bad. Metal restorations are predictable. Metal restorations, and actually nowadays, there is a way to bond metal restorations. It's just not really taught in schools, and it's very technique sensitive. Luted, meaning cemented metal restorations, are very easy to do. It's very predictable in dental students' hands and in majority of dentists' hands. It's hard to do it wrong because you don't have to isolate. You don't have to isolate it from saliva, right? Bonding is very difficult to do, but cementing is very easy. So metal restorations are very predictable for dentists not very experienced in bonding. And yes, gold is still the strongest material and also the most predictable material in terms of longevity. Nothing beats gold, okay? The only issue is it's hard to do gold where it shows, and nowadays patients, it's getting difficult. It's difficult for patients to accept a gold restoration if aesthetics is a concern, because no one wants a gold, gold to show. You know what I'm saying? So gold is more common for like the most back teeth where there's really heavy bite forces and it doesn't really show. But for front teeth, almost never done. Or even like premolars, it can show. So like it's most often done in molars. But I would make this statement. I think MOD, amalgams, MOD meaning like it goes all the way across the tooth in the middle, right? Amalgam placed MOD amalgams should be avoided at all costs. I think MOD amalgams destroy teeth. And let me give you proof. So this is a patient, my patient. I'm not gonna say his name for privacy purposes, but here, MOD amalgam here, and then on the top here on the buccal side, it's a glass ionomer temporary restoration because his buccal cusp fractured off. When you have an MOD amalgam, it's not bonded, so the cusps are just flexing. It's a matter of time before one of them break. And this is the maxillary tooth. Remember the weak tension cusp? It's the buccal cusp, right? So the non-functional cusp, the tension cusp, the buccal cusp here, fractured off. Very, very you can predict this ahead of time. Like if you see an MOD amalgam on a maxillary posterior, you can expect the buccal cusp to fracture off. And I removed the amalgam, I removed the glass ionomer and had one wall remaining. And there's not much ferrule on the buccal side either. Ferrule is a term, can't explain it here, but dental students will know what it is. And so I talked to the patient about, faculty said, and rightfully so, faculty said, okay, you can't get retention form here. You can't get retention, right? Not enough walls of tooth structure remaining. You got to do intentional endo. The tooth was vital, no endo, no infection, but faculty recommended to do root canal so we can put a post in the root for retention, right? Retention of the buildup. So I was like, that's kind of aggressive. Let me discuss with my patient. I discussed with my patient. I told him the risk, benefits, and alternatives of root canal with post versus no root canal with post with just the pin and a buildup. And the patient thought it was also aggressive, and he understood the risks of not doing root canal and a post. And I got his informed consent on this. So yeah, we decided not to do root canal. We decided to place a pin here for retention of the buildup. I'm going to do a composite buildup on this to build it back up. And the lingual cusp here, I've prepped it for a crown prep. See, I didn't want to do a crown on this tooth because I have to remove even more tooth structure, right? As I discussed before. But unfortunately in school, the covering faculty did not agree with me that I can do an onlay on this because he doesn't trust the bond. He thinks there's no retention form. So he told me, do a crown and hold the tooth together. So, in dental school, you can argue with faculty to a certain extent, but usually not a good idea to argue with faculty. So I informed the patient about the risks of doing it this way. The patient understood. I said there's about a 30% chance that your crown could fracture off, but I'll do my best to make sure that everything is bonded, the buildup is really bonded really nicely. I get some more ferrule, and yeah, we'll go from there. So what I did here was I put IDS, image-dentin sealing, decoupling with time. DWT is decoupling with time. I waited 5 minutes for the bond to mature so that the hybrid layer is more mature. I placed the pin there in the buccal side, avoiding the pulp. And I didn't take a picture of this, but I put a small flowable liner layer, sort of as a liner afterwards. And then I used a Packable composite to build this tooth back up from bottom to top. I used about 5 to 6 layers. If you use composite incrementally, there's less chances of very strong shrinkage stress causing a debond. So I put composite in layers, and then I cured every time, and then I prepped it into a full gold crown. At the time, faculty recommended me to do a gold crown because at my school, gold is very, very looked favorably upon. We have a whole club on gold restorations. Gold is very predictable. The only issue here is that gold is not, in my opinion, right? The only issue I see here is that gold is not bonded, right? So the gold is going to move separately from the tooth, right? And because there was one wall remaining on this tooth, there's a small chance that the whole crown portion of the tooth snaps off. Does that make sense? Because the crown is not bonded, it's not glued on, right? So that was my, I've warned the patient about all of these things, but the alternative was endodontics and post. And I don't know if that's probably a little bit better, but I didn't know if it was that much better because there's not a lot of tooth structure remaining. There's not a lot of ferrule. And without much ferrule, posts tend to fracture the root in half. And that's completely unrepairable, complete catastrophic failure. So I thought, this option at least, will probably, if it fractures, it could be catastrophic, but there's also a small chance that it might not be catastrophic. So I warned the patient about this, and he said yes, and we decided to move forward with the gold crown. That's my prep, and this is my impression. The prep and impression was good. So discussion, as I said, I would have done ideally a bonded onlay. Keep that lingual cusps, and then just bond the rest, right? But yeah, unfortunately, faculty recommended full coverage and gold, so I went with that, and the patient understood. Patient also wanted gold. You can see he has gold restorations right next to his tooth. His mouth is full of gold. He's completely bought the idea that gold lasts forever and gold is the end all be all. He's been a patient at UCLA for a while. Faculty recommended also do intentional endodontics and post. Maybe this could have been better, maybe not. But in these cases, the patient always has to be informed of the risk, benefits, and alternatives, which is what I did, and make sure to get informed consent as well. So yeah, just some thought experiment. What would you do? No right answers. And these are some references. And yeah, thank you for sticking around. That was a long lecture, but I love this stuff. So yeah, I had fun making this presentation. And if you have any questions, please message me. Usually I'm very responsive on my Instagram. This is my Instagram handle. You can message me about this lecture if you want to learn more, or if you are pre-dental and you want to, you have any other questions about dental school admission and stuff, or what third-year dental school is like. I'm a third year now, so let me know. And yeah, toodles.